favorite people in Foxy. And if I start reading about his accomplishments, I think your time would be really gone. He was the past president of Foxy. He is the director of Anne Donald School of Ultrasound, and he was vice president of FOG, past president of ISAR, and he has many awards, many lecture, many publications, and more important that he is a multifaceted, multitasking person. I just saw pic of him in one of the groups. He has 12 arms like Durga, doing this together, and whenever we have had the opportunity to listen to him, he's always made the subject very interesting and easy. That is one of his qualities, how you bring out the subject. So I'm eagerly waiting to listen to him about this new wonder molecule, dydrogesterone, which is everywhere nowadays. So Dr. Narendra Malhotra, over to
I
you.
would like I would like to add here. Good morning, sir. You are mentor of so many doctors all over India and world. And happy Guru Purnima on behalf of everybody. And you are my mentor too. Welcome, sir.
Thank you, Rakhi. Thank you, Dr. Achla, for your kind words. It's indeed a very, very busy day. We call it, instead of a happy World IVF Day, a happy World Webinar Day. So I think we have to be at five places after this. I'm going to take you through the journey of progesterone. Let me say there's a disclaimer. I am not being sponsored by any company to mention any names. I am not going to name any drugs, even though this webinar might come as an academic support from some. But we will discuss progesterone, which and what. We know infertility in India is huge. 60 to 80 million couples in India, 15%, as high as 15%. And we know during infertility, we have to do certain tests. And most of us are doing these tests, except probably no one is doing a clomiphene challenge test. You do it during IUI stimulation, and nobody is doing a GnRH stimulation test. But we do all these, and nobody is now doing an exogenous FSH for ovarian reserve. It's AMH with ultrasound. So these will set the context of the talk. And then based on this, we have a diagnostic algorithm on how do we go about infertility, ovulatory, non-ovulatory, tubal block, who needs ART, who needs progesterone therapy alone. If it is recurrent abortion, everything is right there. As just pregnancy failures, they need only progesterone therapy. Some tubal and andrological factors will need ART, and ovulatory dysfunction, 30% will need ovulation induction plus progesterone support. So with infertility comes BOH also, or recurrent pregnancy loss. So we have infertility, we have subfertility, and this will encompass preterm births and miscarriages also, because to some extent, the progesterone therapy is similar for all of them. And that is where we are aiming as to attain a sufficient progesterone levels for a clinical target. And we know it was Sagar Jones who discovered progesterone, who described LPD. And then they said that if you don't have progesterone, the endometrium does not grow and embryo does not implant, way back. And she died just 15 years back in 2005. So LPD is just not only progesterone deficiency, it's a lot of luteal phase defect, could be even anatomical, polyps and fibroids also. So high level of prolactin, poor follicular phase. So you don't have good follicles, you don't have good granulosa cell, they're not converted into theca cells, and you have progesterone deficiency. Premature LH stimulation in PCODs, high abnormal LH levels in athletes, endometriosis, infections, coughs, fibroids. Endometrium itself is destroyed and does not have the progesterone receptors. So the defect could be anywhere, and the defect will lead to normal embryo not implanting. And our aim is so that the progesterone level comes to normal and a good embryo endometrial dialogue occurs, and a cytokine and all the biochemical reactions occur here, so that we get a normal embryo implantation and growth. Now, there is always going to be a controversy on LPD. A lot of people used to say that there is nothing as LPD because of diagnosis. And LPD can be seen with normal progesterone, as I told you. And there is no correlation between endometrial histology and serum progesterone. So there's no role of doing a premenstrual or a day 26 endometrial biopsy just to say it is over, which we were taught in 1986. At present, we cannot say there is one single stamp which will say it is a luteal phase defect. But there could be a E to P ratio, which many papers now suggest. So in diagnosis of a luteal phase defect, we must also keep in mind the unexplained infertility, the age, history of recurrent abortions, strenuous exercises, underweight or sudden weight loss, secondary amenorrhea, prolactinemia, hypothyroidism. So let's divide this section into some protocols, some support, and some evidences. So IVF protocols, which we all follow in different patients. Now it is going to be individualized. So you have normal responders, poor responders, hyper responders, and based on all these, you individualize your treatment in IVF. So best treatment tailored to patient's unique characteristics. So it maximizes her chance of pregnancy and eliminates the risk of hyperstimulation and failure. So personalization of IVF treatment is the today's dictum. And this could be via the long protocol, via the short protocol, or via the minimum stimulation protocol. And ultimately, we're all going to follow the minimal stimulation protocol. So we all know what is a long protocol. You downregulate in the previous cycle, and then you stimulate from day 1 and day 2. The antagonist protocol, you start stimulating and then add antagonist on day 6 or day 7, fixed to a regime or variable, 3 or 4 injections, whatever. And the minimum will be a clomiphene gonadotrophin stimulation with antagonist. So reduces the cost and everything. Now, pituitary desensitization occurs with long protocol. So you get higher number of oocytes and viable embryos, and they can be cryophorosed. So that's the advantage, that in one stimulation, you could probably do 2 or 3 cycles. While the short protocol is preferred for PCOS and poor responders. So you don't get too many, but you get enough because you're stimulating from day 1 without downregulation. So you don't need a very high dose of gonadotropins also. So what we see is that there is a decreased follicular development in patients with normal function, and the androgenic effects of clomiphene has to be balanced with so the protocols need to be balanced. What I want to say with all these 3 or 4 slides is that the protocols have to be individualized. The same clothes do not fit every woman. Every woman, the sizes are different and the sizes matter. And that is how the protocols also matter. So depending on whether they are poor, whether they, or you need to change your protocol depending on whether ultra flare, short or what. Now, after deciding a protocol for ART, we now come to do we need a luteal phase support? And why do we need it? And then we will come to what will be it, and then we'll support it with some evidence. So formally, it was believed that all the granulosa cells are removed during ovum pickup, so you have to give it to all. And GnRH also suppresses FSH-LH, so you have to give it to all. HCG ovulation trigger suppresses LH in stimulated and non-stimulated. So these were in 79s and 90s, these were the beliefs. Now, why luteal phase in IVF? Antagonist cycle can reduce the luteal phase length, we know that. And luteal phase fixed length of 14 days is mandatory, otherwise is going to cause failure. So these were the 2000 references. Then you get supraphysiological levels of E2 because you're stimulating, you're getting many figure, and that could be detrimental. That is why these days freeze-all technique works better. Then the corpus luteum requires a constant LH stimulation, and if you withdraw the HCG support, and that could cause LH support, that could cause luteolysis. So there is a role of giving an LH support after the embryo implantation also. So luteal phase deficiency is characterized by low progesterone levels, delayed endometrial secretory transformation, shortened luteal phase than the 10 days. And this will reduce the embryo implantation, reduce the pregnancy rates, and cause increase in miscarriages. That is happening. Now, when we say that we need a luteal support, so then there is the next debate comes in, when to start it. So there is no difference of starting luteal phase support on the day of oocyte retrieval or the day of embryo transfer. No difference seen whatever is the day of HCG or ET. But it should not be more than 3 days later after the ovum retrieval. That has to be kept in mind. So if it's going to be a day 5 ET, the luteal phase should start, the luteal support should start the next day or on the day of the ovum retrieval. And LPD should be given, should be up to a positive HCG. After that, it is no role. And we are all giving all sorts of progesterone till probably 5, 7, maybe some are giving till 9 months. But there is no role when you get the positive beta HCG, or maximum those who have bad obstetric history, give it at 12 weeks. And then the placenta takes over. So a correct ovulation induction, so you get a good follicular phase, a good HCG trigger and HCG supplementation or LH supplementation, and starting of progesterone, natural micronized progestogens, dydrogesterone, and also GnRH agonists. That would be our gamete. And there are going to be many protocols: luteal phase support with progesterone only, luteal phase support with HCG only, and luteal phase support with agonist. So if you give it with progesterone only, that is the standard approach of all of us in IVF cycles. And if you give it with HCG, there is a high risk of OHSS. So we avoid this. And the agonist can be. So the therapy would be progesterone, HCG, and progestogens. We will not go into the whole lecture of progesterone. It's very interesting how progesterones have evolved from natural from 17 to 19 and then to progestogens. But what we should know that progesterone improves endometrial receptivity and it promotes local vasodilatation by nitric oxide release in the endometrial cells. So the spiral arteries dilate and you get a good blood flow. So secretory endometrial transformation and vascular improvement occurs whenever you give progesterone correctly. So local vasodilation plus, because nitric oxide is a relaxant, it will make the uterus quiescent. So the uterine relaxation property of progesterone prevents the expulsion of the embryo during the transfer. Plus one more thing will happen, which we'll just discuss. So how do we give natural progesterone? It started with intranasal, sublingual, rectal, not used any longer. You can give it orally, you can give it vaginally, and you can give it intramuscular. This is progesterone. The injectable is subcutaneous or intramuscular, but poor patient compliance because very painful injections. When we started IVF in 1995, 96, this was the only way it was given, and 90 injections were very, very painful. Vaginal suppositories and tablets and gels and effervescent tablets came, which proved to be good, but then they are very messy, and Indian women usually don't like things, medicines to be kept in the vagina. So that again is a big no-no. Then came oral natural progesterone or micronized. You have good patient compliance. Patient is very happy you're taking oral tablets, but then this is not going to give you the correct progesterone levels. So intramuscular, oral dydrogesterone, and micronized, and these are the options which we have for progesterone. Now, oral micronized, low bioavailability, injectable pain, and micronized vaginal irritation, and micronized oral, again, low bioavailability, drowsiness, headaches. So probably the most potent oral progestogen, which gives a good bioavailability today, is proven. Dydrogesterone has proven to it. Now we can give progesterone in combination, progesterone estradiol combinations, progesterone ascorbic acid combination, progesterone prednisolone, progesterone aspirin, depending on what the condition is. Recurrent aborters and progesterone aspirin and low molecular weight heparin combinations. So these are where it can be, but then they have limited roles and they were given in specific indications. So oral, as I told you, is going to have the sedative, hypnotic, drowsiness, flushing, and nausea, and fluid retention, and has a lower pregnancy rate as compared to the others. Micronized oral, yes, better than natural oral, but still has all those effects. Dydrogesterone is the only oral progestogen, which is effective and well tolerated. Intramuscular, very good, but uncomfortable. 90 injections, very painful. Inflammation, eosinophilic pneumonias, all those are there. And once a week injections, hydroxyprogesterone, which when we were students, this was the only thing available. They're oily based, they are painful, but 250 to 500 for pregnancy support up to 12 weeks is quite good. But the patient discomfort once a week, the aqueous solution. Vaginal will bypass the liver. If you keep something in the vaginal cuff, it gets directly absorbed and direct action on the uterus has been shown by this experiment. So this could be a preferential, but again, the patient compliance has to be looked at. And especially in hot, humid countries and patients with vaginal infections discharge, this may not be the best way to give it. So otherwise, vaginal gel and vaginal effervescent tablets or vaginal could be very, very good. Now, micronization of progesterone is that you made the molecule very micronized or the particles. So the absorption improves, the oral and even the vaginal. Yes, it improves, but vis-a-vis the other, we need to compare it. And progesterone gel is still very good and as good as the injection probably. For first luteal support, first 14 days in the pregnancy after embryo transfers. What about the effervescent tablets? When you keep the effervescent tablet, it dissolves here and it gets a passive through the cell and in between the cell also. So that can happen with effervescent tablets in 24 to 32 hours. It can show its effect and 10 nanogram concentration. Now, in India, we have about 40,000 cycles being performed. And most of the surveys by all the IVF centers show that patients preferred an oral route. So now we come to the section where let's see the evidence of which progesterone. And there's this wonder molecule which every company is now jumped in. And we already have eight brands available as of today. Maybe the 9th one is on the way as of today available to us, confusing us doctors a lot. So pregnancy, even progesterone does that, but pregnancy we know is 50% of husbands. So there is an antigen, foreign antigen coming in, and yet it is not rejected. So why it is not rejected? Because the change of the T cell, T1 helper cell response to T2 helper cell response. And this T2 helper cells protects the fetus, and this protects the fetus, and the response with the T2 helper cells occurs more when you give progesterone and when you give dydrogesterone. This was the first paper presented long back in late 1990s in a Hong Kong Congress. And since then, the molecule has become very popular. So vis-a-vis dydrogesterone and natural progesterone, both do have immunomodulation, but dydrogesterone probably has a little more of immunomodulation and hence is used, and the immunomodulation effect comes effective as soon as the embryo enters into the embryo cavity. So dydrogesterone is a retroprogesterone with an additional double bond on carbon 6 and 7. It is highly selective to the endoprogesterone receptors. It has got a better bioavailability, no side effects, and it's got low side effects. So no natural progesterone oral side effects. And 6 times greater oral micronized progesterone availability at the dose of only 10 milligrams, low dose, and negligible side effects. So good bioavailability, effective dose, plethora, and given in threatened abortion. And it causes the T2 cells to increase, T2 helper cells, that is protection of the fetus. So it gives you more of a better outcome. And if you don't give any progesterone, then this would happen to the fetus. The T1 cells, the harmful cytokines will start the interleukin 2 and the natural killer cell activation, and that causes abortion. So recurrent abortion, one of the major causes this, and not torch. A lot of people think torch is the major cause. So don't do torch infection, do study on this. So dydrogesterone will be blocking here and helping here. Induces the progesterone-induced blocking factor, PIBF, and that helps it. So we have Indian evidences, luteal support on this study. We have Dr. Patki's evidence, and we have Dr. Ganesh's evidence on study population, main results. These are papers which all of you can study. I'm not going to go into the details. They just say that it compares oral dydrogesterone versus the micronized vaginal progesterone, and both may be same effective, but then there are some advantages which the oral have Lastly, in frozen embryo transfer cycles. Again, in frozen embryo transfer cycles, preparation of endometrium is very important in the non-stimulated cycle. So again, here in the fresh, you see it is like that. Because of high E2 levels, the failures are more. And when you do a frozen embryo, you need only progesterone preparation. And this can be very, very easily done in women with PCOS, women with ovulation, ovulatory, women undergoing PGTA, waiting for the response. And you get a very, very good pregnancy rate with to the tune of some 84% when you give a good progesterone support with dihydrogesterone. So freeze-all technique has its own indications, and freeze-all techniques lead to frozen embryo transfers, and that is where the preparation of exogenous progestogens is more important for preparing this. And there is enough evidence now that we need to prepare the endometrium properly, either by intramuscular or by dihydrogesterone. So the key messages, ladies and gentlemen, is that worldwide 60 to 80 million couples suffer from infertility. And out of this, 20 million are in India alone. And individualization of treatment is very important. Lack of ovulation in artificial frozen thawed cycles need to be prepared by progesterone very well. And oral dihydrogesterone today is proving to be a good alternative to even micronized vaginal progesterone. And again, a lot of papers to support this by Gissinger, by Amit Patki and Vijay, by Azam et al. And Batul Hussain, by Nolofor et al. Again, you can read all these, by Gopinath and Desai, by Aruna Nigam, luteal phase support, how when, by an open label prospective study, by our center, Dr. Jaydeep, with correlating with the international centers and dihydrogesterone safe and well tolerated. This was in oral stimulated unexplained infertility, and a very nice way we tried to, and by Herman et al. And by Federici. So I would like to end that today, despite of the progesterone being understood, is like a lady with her eyes seen only. Her full face is yet to be revealed. In spite of being a basic sex steroid, progesterone substance still remains full of surprises. And today, still it is universally accepted that we need to support pregnancies. And in a lot of common gynecologists and peripheral gynecologists, the progesterone therapy, pregnancy has become an indication for progesterone therapy, and it's being continued for whole of 9 months. And that we need to stop, and only where it is indicated, it should be given and where. So thank you very much, Jyoti, for giving me this opportunity to express some of my views on progesterone and the molecules we have and their pros and cons.
Thank you so much, sir. As usual, a spellbound lecture, and we were just frozen, like the frozen embryo hearing you. Sir, can I have a question with you, sir? Can I ask a question, sir?
Sure, most welcome.
Sir, as we have come to know that patients who have a risk of preterm delivery, so they were saying that micronized progesterone do help in such patients. So if a patient is on this dihydrogesterone, and after 12 weeks, then the patients with high risk of preterm labor pains, we need to shift them to micronized progesterone, continue this only.
So immunomodulation and uterine quiescence. These are the two things which we need for the pregnancy to continue till term. And immunomodulation is covered better by dihydrogesterone, and quiescence of the uterus is covered well by both of them. So you can continue the dihydrogesterone till 28 or 30 weeks whenever you feel is viable. And if you're going to switch to micronized, the dose has to be only 200 and not 800 or as high, which we give for support. So for supporting the luteal phase, it's 200 3 times a day or even 4 times a day in divided doses. But for uterine quiescence or prevention of preterm, it is 200 only. But dihydrogesterone also works equally. So
we can add both?
Whether you can give 2 progesterone, both or 3, I know every one of us is giving all three also, once a week injection, vaginal tablet, and
All this
dydrogesterone and micronized. Now that is an individual choice. One progesterone is enough.
But we need a word from you. Matlab one is.
One is enough. But I don't think everyone will listen to my word, including myself, and because we are scared, and we're scared, and we usually use two progesterones, but there is no evidence of using two progesterones.
Okay. Thank you so much, sir.
It is like that dialogue, sir. वो सलमान का dialogue है ना कि मैं अपनी भी नहीं सुनता. So so yes, the same thing. But okay, I single though I say, but I will not listen to that. Thank you so much, sir, for that fantabulous talk. Achla ma'am, your words, and then we come on to the next session.
Yeah, I just want to say that don't be like Salman Khan. अपनी भी सुनो और लोगों को भी अपनी बात सुनवाओ. And I think we should insist that use only one kind of progesterone or not use 3 kinds. And that because otherwise a very, very nice crisp lecture and the importance of progesterone has been fully explained, and also the usefulness of dydrogesterone. But definitely I would like to again reiterate, please, if you say, people will listen.
Use only one. I would say my punchline is use only one.
Yeah, our Amitabh Bachchan of our industry, Dr. NM says use only one, so we will use only one progesterone. So that is what we should take home on this World IVF Day, not to use try using everything. I mean, one is more than enough, I think. So thank you so much, sir, for joining.
I can be excused, but I have to join the other thing.
Sure,
Hello,
sir.
Neeta. Hello, Neeta Singh. How are you?
I'm fine. I would just like to add what
Yeah.
Dr. Achla and Dr. NN said. Use evidence-based. Okay, use one and based on the current evidence and the research, not what everyone says.
Sure, ma'am. So thank you so much. Before we move on to the panel that we are eagerly looking forward to, we will have a short video. Since this is the launch of a short, the Divatron is being launched. So can we have the short video there? And then we will move on to the